You're pointing at me. You didn't do the countdown.
3, 2, 1, begin.
All right. He was pointing at me. He said he was going to count down and point at me. So good morning, everybody. We're going to talk about peds trauma. Got some other housekeeping stuff first. Most of our videos, since it's summertime, are pool related, some with injuries, a lot with not. So enjoy. So the first thing I want to bring up, which is not related to peds trauma, is that countywide we are going to be having a discussion on ketamine, which I think is a good thing. And I actually initiated the discussion. And the reason is you can see that there's some news stories up there, and you may have seen them or heard about them. And the issue was over the forced administration of ketamine to a patient who was in police custody, who then subsequently coded and then died. So the issues that came to light with that is, one, did they give too much ketamine? And that's a question I think is still, I'm not really sure, but the dose they administered was 500 milligrams IV to a kid that from the videos looked like he was about $1.20 soaking wet. So that probably was a fairly significant dose. So there's a few issues that come up here. One is that whenever we're called by the police to help with subduing a patient, who is our duty to? First of all, is our duty to the patient? Is our duty to the police? I think that just like every single call that you end up being involved with, I would ask you to do an evaluation and use your best judgment. Meaning that if you are able to start an IV on a patient, do they really need a forced administration of a drug to subdue them, right? If someone's excited delirium and you can start an IV, does that really fit with excited delirium? Because I would say that really if they're still enough that you can start an IV, then you need to be rethinking that. I would also say that I think ketamine is a safe drug. I think ketamine is a useful drug. I do not think ketamine is going to go away from our protocol, and I think it's a necessary drug in excited delirium. But what the discussion I'm having is more to look at this and just make sure that we're being safe with this drug and we're being clear on the dosing and probably clear on the indications as well, so that if this ever does get called into question, we can say with a clear conscience that we have looked at it, we've considered it, and we're trying to do the safest thing that we can. I think what's going to come out of this is probably some clarity in the dosing, some clarity on the diagnosis of excited delirium, because right now, based on the protocol, it's very vague. Pretty much they have a lot of weird criteria, but it doesn't really say there's anything that they have to have or not have to have. And then the other thing that I've said before is that excited delirium carries a mortality of about 3 to 10% wherever you look, right? That's pretty high. So if you're thinking that 1 in 10 of these patients are going to die, the problem, and that's without administration of medications, drugs, tasers being tied down. If you're thinking that 1 in 10 of these patients are going to die, that means that you need to be very careful to try to figure out who that patient is. Meaning that once you administer ketamine to these patients, your goal isn't just to sedate them so they can go into police custody. Your goal is that you are sedating them so that you can evaluate a critically ill patient who just happens to be running around and fighting you. And so what I expect to see in the protocol change would be language that necessitates that you're going to be monitoring the patient, putting a pulse ox on them, looking for airway compromise, being ready for the fact that they may develop laryngospasm and may need to have airway management pretty urgently. And then there'll be some sort of language in there that says that once the ketamine's administered, that we are now going to be aggressively monitoring these patients so that for that 3 to 10% that may code on us, we're ready for that rather than it look like we killed a patient, right? And that's the way it looks, right? You take a patient, and that was the same debate we had with tasers. It's the debate that we have with the LVNRs, is that there's a risk out there. And sometimes that risk truly is from that proximate cause, right? You have the administration of ketamine and a patient dies. Does that mean the ketamine killed them? Not necessarily in this case. However, in the eye of the public, it's going to look like it. And so I feel that we just need to be really careful in who we choose to give this to, careful on how we observe the patient and document. And really, I guess, the documentation is also key that, if you have a patient who doesn't really appear to be a threat, are they someone that we should be administering ketamine to? I would wager no. I think that ketamine is a drug that makes people compliant. And we talk in the PAM course about how ketamine is compliance in a jar. We talk about that for the DSI. And unfortunately, for someone who is being, arrested and is in a situation against their will, we just need to be careful about that in this day and age, because I think that if we're not careful with this and we have problems, people that have no knowledge of medicine are going to be deciding what we can and can't do. The other thing about ketamine, just since we're on the discussion, is I would like to expand its use in the protocol, because I do think it's a very safe and useful drug. And I think that what I would like to see is that we have some sort of procedural sedation protocol that involves ketamine for things like painful procedures, things like cardioversions, reduction of fractures, because I think compared to the other agents that we carry, I guess your choices would probably be between fentanyl, Versed, and etomidate. I think ketamine has much, much better safety profile than any of those agents, and I'll stand behind this drug, but I just think that we need to be very diligent in our usage of it. I don't know if anyone has any questions on that, but I'm glad to answer any. Okay. If any come up in the near future, just go ahead and shoot it, because just because it's not asked now doesn't mean I won't answer it.
Steve, is that
Yep.
on the agenda for the EMS meeting tomorrow? The county EMS meeting?
So yes, it's on the agenda, and I've been talking to Barnhart, Gates, and Waffle, and Gates, Barnhart, and I have drafted a letter to Pierce County EMS just saying what we would like to see and just how to make sure this drug is safer. There was talk about considering other agents instead of or in lieu of ketamine, but to be honest, if you look at Haldol or you look at droperidol, they take too long to kick in. They also have black box warnings and safety issues. And I feel that ketamine is still a safe drug. We just need to be making sure that we're using it in a safe way. Anything else? Nothing? Now you're just drinking. That's a really big jug of water. Or is that milk? Is that a big jug of whole milk?
I'm not going to tell you what's in there. It's better that you don't know.
Milk on top, bourbon on the bottom.
It's gravy.
It's gravy. Nice. Gravy, good. Gravy with some chocolate chips in it. All right. So RRC Parkland, you guys may have heard about this, but the opening was supposed to be next Wednesday. It's now delayed until October because of construction and other issues, and so there'll be more to follow on that we know more. This is something that I am kind of glad it's delayed a little bit. I think the site care is needed, but I think that also gives us a little more time to talk with some of the leaders in administration to make sure that this isn't overly burdensome to us. In the same way that RRC Fife has been a little bit of a burden to Tacoma Fire. So I just want to make sure that we have all the pieces in place, but we now have a few months of reprieve. In other notes, the OCED on South Hill is scheduled to open on time next Wednesday. Is that the 29th? Is that right? I think so. Yeah, the 29th. I think that's Wednesday next week. So that has the same receiving capabilities as the other OCEDs. So for those of you that are familiar with the Parkland, you should know what they can take. The general rule of thumb that I would just consider is if you're looking at someone and saying, man, they're really sick, they need to be admitted to a hospital, they probably shouldn't be going to the OCED, because that's just going to mean that you're dropping them off there so they can be transferred somewhere else. The other things of note is that if they can't walk, if they have a psychiatric issue, when I say can't walk, and we're not talking about like an ankle injury, I'm talking about like they're too weak to walk or they have paralysis, they should not be going there. If they're going to need a cath lab, a neurosurgeon, a trauma surgeon, they should not be going there. Those are kind of the general rules of thumb. If you're working near the South Hill OCED and are planning on using it, I would familiarize yourself with the list for specifics. And also, if you're going there and you're on the fence about, I'm not sure if you can take this or not, lead with that when you're going there and say, hey, this is what I'm bringing. I'm not sure if this is appropriate or something you'd want. Or if you think it's something that blurs the lines a little bit, then have a discussion and figure it out. Also, their ability for psychiatric care is limited as well because they don't have the social worker. They've got limited staff, so it's not like they can have someone sit with someone. And definitely if somebody is out of control or violent, I think they've got a tech, 2 staff members, 1 security guard, and a doc. So if there's someone who is at risk for psychiatric issues and is going to get violent or need restraints, that's also not the place for them because they don't have the manpower to do that. Anything else on OCD? Joe and I are, I think, going to go look at it this afternoon just to kind of pop our heads in.
Yeah, so additionally, we'll have all of the phone numbers loaded onto the phones within the next couple days.
Oh, you want a mic?
What's that?
You want a mic, or are you just trusting on everyone can hear you?
I'm just trusting everyone here.
I'm pretty sure they can.
So we've added the phone number for the South Hill OCD to all the phones. We will also be emailing out the inclusion and exclusion criteria like we did last time. They're on most of the EPCRs and MDCs now, the exclusion and inclusion criteria, although they're not on all of them, so we're going to make sure it's on all of them. On the sit rep today, you'll see that there are some directions if you want to stop by the clinic the ED between 0900 and 1400 hours to do a walkthrough. Dr. Justice and Dr. Satterley will be there to greet you. So if time allows, if you guys want to do it in between calls or in between training, please do so to familiarize yourself with the ER.
We've been working pretty hard with Heather Justice, and she's done an amazing job with arranging transport out of the Parkland OCED so that this has been a positive experience, I would have to say, for us in general. I expect the same thing to be going on with the South Hill OCED, where we're not going to be getting tapped out to bail them out. However, on the occasion that you do, I would ask that you are cordial, you evaluate the situation, and then do the right thing for the patient, and then let us know, because Joe and I would like to be notified of everything, and we're going to be aware of it probably, but we want to be notified of everything that we're transporting out of there so we can evaluate that, redirect, and make sure that we're not being overburdened by this. The concern, that I think they're addressing, but I would want to know, is that if their contracted private service is not able to meet the demand, and this is something that we're becoming a 911 call of convenience, then that's something we need to know about right away and nip in the bud. However, if you're being called for transport of a STEMI and their transport is not available, yeah, by all means take the patient. If you get someone that's there and shot in the chest and they need to get the person out of Dodge to trauma as fast as possible, yeah, by all means do the right thing. But again, this is something we want to keep close tabs on. I don't really have anything else to say on the OCED. I anticipate, the other thing of note is that Paul Satterley, you may know him, he works down at Good Sam, so he's the assistant medical director there. So that's someone that's in our area working at Good Sam. Heather works at Teacup down at Tacoma General. They've been both really great to work with getting this set up, and they want to make sure that we're happy with how it goes as well. Last thing, COVID update, is that if you're paying attention to the news or the Pierce County, I get the Tacoma Pierce County update every day with the COVID case counts. You may have noticed that those are rising. We were, for a while, in the very low numbers. We were seeing 5, 10, 15 a day. We've now crept up into the higher numbers. Over the weekend, we were up into the hundreds. So we've been hitting the hundreds and the 90s. Some of that are the outbreaks that made Cairo news in our area, which is just blanked on the name, help me out, the Life Care of Puyallup, and then the Oaks in Lakewood has an outbreak, and then UP Care Center has an outbreak. So those are all Pierce County nursing homes. There's a pretty large mix of staff and patients that have it. In addition, the counts at Good Sam are on the rise. We, about 2 weeks ago, had 4 patients, and then we crept up through the teens last week, and now we have, I think today, as of today, we have 22 patients at Good Sam who are admitted with COVID. So things are creeping up a little bit. The ER has not yet been overwhelmed, but even though the weather is not conducive to wearing appropriate PPE, be suspicious of it and be ready. I reviewed a call that was a Central Pierce call last night, and then there was a big call last week that was a West Pierce call, both of which were trauma calls. Before patients go to the OR at almost all facilities in the area, they're getting a COVID swab, just because they're looking at what kind of decontam and how much risk they are to the providers. But we had 2 trauma cases. One was the big West Pierce one that was the guy hit by the train down in Steilacoom, who had contact with 17 West Pierce firefighters and the crew of Airlift Northwest, and he was COVID positive. So that resulted in 8 exposures at West Pierce and 8 quarantines. The other case I reviewed was that I was sort of a surprise, but this was a guy that was hit by a car while in a wheelchair and crossing the street, and he went down to trauma, and he was COVID positive. So the message there is that, of course, if they've got fever, cough, headache, flu symptoms, be suspicious of COVID, but the big message is that it's out there, and I think that we're very fortunate to have put in a lot of measures into place to have available PPE for people so that you can take precautions with a lot of calls. Now, I know that wearing an APR and a mask and a gown is not something you want to be doing when it's 90 degrees outside and sunny. Unfortunately, that's probably the safest thing to be doing. So if you're going to be having close patient contact, be very suspicious. Obviously, if you're doing aerosolizing procedures, you need the full meal deal. But I think with patient contact in general, just be suspicious that it's out there, because we're seeing it in cases that are not trauma cases, because it's now in the community and there's community spread. The other things of note about COVID is that as a result of increased testing, the reagent is in short supply. What does that mean? It means that COVID tests are taking longer. So the rapid COVID test that was happening at Good Sam, and we were actually doing pretty well and having 4-hour turnarounds, we only have around 8 of those per day. So we are doing the rapid screening on the people that need emergent surgery. The rest are going to TG. The turnaround time for those was 12 hours or so. Now it's stretching out into the days, and then UW is stretching out a little bit too. So turnaround times are not fast, and that's because of limitation of the reagent. And I think part of it is just that as we've seen more cases go up countrywide, then the reagent's just getting used up more, and we're having to compete with Texas and Florida and Arizona and California, who are also having increased testing and increased case counts. So I appreciate you guys being diligent. And I know that it's tough to wear the PPE, but we know that the PPE works, and it's really the best stuff we have to protect ourselves and our families from this. I don't know if you have any other notes on this, Joe. I think.
No.
Your microphone.
No, we talked about it extensively at leadership meeting yesterday.
Mike. All right.
We talked about it extensively at leadership meeting yesterday, and given the fact that West Pierce has had a number of people in quarantine, TFD has had a number of people in quarantine, we just have to keep staying the course. There's just no other way to do it right now.
Yeah. I mean, it's unfortunate, but it's the way where we are, right? It's what we're doing. I guess the last thing to bring up, I don't have a slide for the last one, but so Madigan is no longer providing base station, and as of the meeting I had this morning, it sounds like they're not going to be a DMCC any longer. There's still discussion going on. So what does that mean to us? I mean, it doesn't mean a ton right now, because it doesn't change how we do business, except that now TFD is using Good Sam as their base station, which means that the base station is just a little bit busier. We're looking to have someone, And this is not something that's going to happen fast, but if things go right, we're looking to have someone who is just manning the base station phone, a nurse whose job is to man the base station phone for peak hours. But that's something that is not going to happen tomorrow. This is something that's off in the distance. There's still discussion about whether one of the downtown hospitals is going to become a base station. There's some talk that's positive to that, some talk that's negative, because part of it is that Good Sam's been doing it, has experience, and has a lot of EMS people that work there. So there's thought that we're pushing to keep base station at Good Sam, but there's still a lot in flux. But I'm just letting you know, mainly because since we're having an increase in call volume, just be prepared that if there's a little bit of a delay, or you're having issues getting a doc on the phone, that could be why. The other thing I would ask is that when you're calling, we've talked about the communication before, but I think that if you're calling and you have a specific code patient, lead with that, meaning that you call, introduce yourself, say who you are, and say, I'm coming to you with a code STEMI, or a step 3 trauma, or a code neuro. Lead with that so it doesn't get lost in the weeds, right? Because the other thing that's of note with increased calls is we're going to have people that are less familiar with answering the phone. The other thing is that if you have a specific question that only a doc can answer, then also put that in early, because just say, hey, I think I'm going to need to talk to a doc about this if you need authorization for a medication. But as you guys know from dealing with base station, most of the charge nurses are pretty good at figuring out when they need a doc or not, and usually a lot of times it's fairly straightforward. I don't know if there's any other base station issues I need to bring up. Not really. I think that now that we're having the issue of some of the ALS downgrades, that's been a little bit of a challenge. But that's just more of something that, since that's something that hasn't been happening at Good Sam before, then it's just a new process, and I think that's getting a little bit better over time.
Has there been discussion about TFD using St. Anthony's for a base station as well?
I'm sure it's been discussed, but I've not been involved in the discussions, so that's something that I don't know. So that's something that I guess could be possible. I think part of it is that since Gates recently took over as physician advisor at Tacoma Fire, he knows, granted he's worked at St. Anthony's, but he also has a hand and knows the process at Good Sam. He likes that, but I don't really know, and I wasn't involved in that process. I think that Hersig and Waffle, so Hersig's the base station physician, and of course Clark Waffle is the MPD. Clark Waffle is very happy with how Good Sam has provided base station services, and as a result, I think feels that it's beneficial that we keep doing the job that we're doing there. So I think that's a lot of the thinking, but I don't know if there's any discussion about that. And I think that really the ask is more, what kind of manpower do we need in order to maintain the level of service that's needed? And I think that's being addressed early rather than, it was just sort of a surprise. This is something that just suddenly happened about 7 days ago and kind of caught everybody off guard. So I'm sure we'll have more discussion at the MPD meeting tomorrow, but I don't know. Anyway, it's yakking for a while. I don't know if we've had any outside questions. Nothing. Radio silence. All right. We'll get one rerun on that. This is why I need the laugh track, Joe. Thank you. So for pediatric trauma, so trauma is the most common cause of death in children greater than a year of age. So really that's a big statistic when you start looking at that. That's huge. So that means that a kid is more likely to die from trauma after 1 year of age until age 18. So that's really enormous. So when you start looking, the highest risk is less than 5 years of age. They do count drowning in trauma. Boys more than girls because boys are idiots. But 87% of the time it's blunt trauma, and it's falls, MVCs, motor pedestrian, recreation, abuse, drowning, and burns are kind of your most common to least common. So 9.2 ED visits a year, 20,000 deaths per year, and 50,000 permanent disabilities per year, and that's in the United States alone of those numbers. The economic impact is $10 billion per year, so that's not chump change. That's a lot of money. So the anatomic differences between kids and adults: they have a relatively larger head, they have a larger body surface area, they have more anterior, less protected abdominal organs, and we'll talk about all three of those things. Physiologically, they can lose a pretty significant amount of blood. So they can lose about 30% of blood loss without a drop in BP. However, what happens is once they are unable to compensate for that, they get sick pretty fast. They have increases, they're able to increase their heart rate and their systemic vascular resistance. And as a result of that, they can compensate pretty well. So if you think about kids as they get sick, they get tachycardic, they clamp down, they get mottled. But the thing that they aren't very good at is increasing their cardiac output and stroke volume, right? They increase the output by speeding up the heart rate, not by some of the other things that adults can do. They have smaller airways. They have increased airway resistance, but also because of a smaller airway, a little bit of swelling goes a long way. So if you have an airway that swells 1 millimeter and it's only 4 millimeters in size, you're getting a significant cut down in the size of that airway, as opposed to an adult which may not have the same amount of compromise. And that plays into trauma, because if you start thinking about what kills kids in trauma, it's usually airway issues and volume issues. So hypothermia is a big deal in kids and in trauma in general. In the corner, that's the trauma triangle of doom. But the hypothermia in kids is more likely due to larger surface area. But when you start looking at what happens in hypothermia, is that they end up getting, the coagulation factors don't work quite as well, so they get a coagulopathy, so they're more likely to bleed, which bleeding is the enemy of trauma patients. That bleeding leads to decreased perfusion. That decreased perfusion leads to lactic acidosis. The metabolic acidosis leads to decreased myocardial performance. And then that all feeds back to hypothermia again, and then things get worse. You get into this feedback loop that then leads to this downward spiral. So some of the things that we can fix in the field are optimizing their perfusion, whether that's going to be through boluses of fluids, whether that's going to be through administration of packed red blood cells if you have airlift on scene, or whether that's through administration of whole blood once the whole blood program starts coming up and running. And then also that we can address the hypothermia, right? So we've got a kid who's out in the rain, in cold air, and we have them exposed, so we can look for injury. Well, as soon as you finish that primary survey and you see there's no big injury, no big bleeding wound, get them covered back up, get them dried off, get them into a warm environment. And then if you have warmed IV fluids, administer those, because if we're administering further cold IV fluids, they're just going to get colder. And so that's all sort of feeds back into itself, and there's some things that we can do to try and reverse that. This is my album cover from my band, Trauma Triangle of Doom. We're on Spotify. Listen to us. We're great. So next, so this is just sort of some simplification of that, right? And if you look where the hypothermia feeds into further bleeding, the coagulopathy gets worse. And then the other thing that's notable, which feeds into the whole blood program, is that traditionally in a trauma patient, we start by giving them IV fluids, right? We give them normal saline, which dilutes out the blood in the clotting factors. And then our next move is we give them packed red blood cells, which again is good for oxygen carrying capacity, but is not good for fixing that coagulopathy they're getting as a result of both hypothermia and as a result of blood loss. So that whole blood program is going to be enormous whenever we are able to step in and administer whole blood early and reverse some of this cascade. Animus. This is the pediatric assessment triangle. I went over this in pretty big detail on 2 months ago. I'm not going to go into it again, but just remember that when you're looking at kids, especially if you can't get a history from the kid and they can't really tell you what they're feeling, looking at their work of breathing can tell you a lot. Looking at their circulation to assess their perfusion, looking for pallor, modeling, or cyanosis, and then also using their mental status as a means of assessing their perfusion, as opposed to just relying on vital signs alone. And here this is sort of the cascade of what kills trauma patients, right? So we get a pediatric trauma patient, and granted, some injuries are preventable, but by the time we're on scene, it's not preventable. It's already happened. So the things that we need to look for and intervene on immediately are any sort of respiratory failure or shock, because if we don't fix those progress to cardiopulmonary failure, which then progresses to cardiopulmonary arrest. And once there's a cardiopulmonary arrest in a trauma patient, their chances of survival are almost nil. So your primary survey, you're going to look at your immediate life threats, of course. You're going to look at airway, breathing, circulation, and critical hemorrhage. And I have another slide on this later, but I'll just bring it up now. But just remember that in a small child, a scalp lac or a lac that wouldn't normally be considered that much of a hemorrhage or a circulatory disability can actually be a significant amount of bleeding. You know, first of all, head lacs bleed like stink. They can have small perforating arteries in them. And so really addressing that early is a good idea. You know, and I like pressure dressings because they can take the workload off of a person. However, if you ever have a difficult to control hemorrhage, really you should be using either your hand or one finger to try and stop it. So if you've got a large hemorrhage, you know, just relying on putting an ABD there to soak it up and then letting that ABD get soaked and put another one on top of it, really if you can stop that hemorrhage with your finger, do that. And then, you know, the pressure dressing maybe can be thought about later, but really if it's a big bleed, usually one finger is going to stop it better than any sort of dressing you can put on there. Next, you're looking for disability, and then of course you're doing your exposure of the patient to look at everything, but then also considering the cold environment and then preventing any sort of environmental heat losses if you can. This is the pediatric Glasgow Coma Scale. I'm not going to go over it, but just know that it exists, and so whenever you're trying to get a GCS on a kid, it's different than the adults. So respiratory-wise, and I've talked about this with my medical pediatric lectures, but just remember kids have double the oxygen demand of an adult when compared pound for pound. So that means that for us, if we have to pre-oxygenate a kid, or if we have to intubate a kid, if we have to paralyze the kid, they're going to desat faster. For a kid that has a pulmonary contusion, you know, they're going to have more oxygen requirement, they're going to desat faster. Infants, so kids less than about 8 months of age, have to breathe through their nose. So a facial contusion, nasal contusion, bloody nose, congested nose to an infant is an airway emergency. You get a two-month-old or a 1-month-old who has their nose occluded, you now have a kid that can't breathe. So just remember that if you can clear that nose in a small kid, that's crucial. Respiratory failure in children is the #1 cause of full arrest, both in medical and trauma emergencies. So remember that you know, your respiratory issues need to be addressed immediately, because once that turns into a full cardiopulmonary arrest, your chances of getting that kid back are significantly decreased. The kids have a cartilaginous chest wall. That means a lot of different things, right? So first of all, it means that they're not likely to get a rib fracture. So you get complete transmission of force through the ribs to the underlying lung tissue or the heart or the mediastinum without the rib fracture. So that means that you could look at the chest wall, not see much in the way of bruising, not feel a step off, and there's significant underlying injury. The other thing is, if you do see a rib fracture, that speaks to the fact that there's significantly more force. So small kids with rib fractures should make you more worried. Surgical airways, there's, you know, a lot of opinion on this, and the thing about it is that we look for a nice airway cutoff or age cutoff, but really the cutoff is the size of the kid, right? So you'll hear some people say 8, some people say 10, some people say 12, but really, you know, it's more the size of the kid. A big 10-year-old, sure, you're probably okay because it comes down to the size of the cricothyroid membrane. Small 12-year-old, you may not be able to do it. A big 10-year-old, you may be able to do it. Huge 8-year-old, yeah, you might be able to pull it off. So really it's size of the kid, and is the kid in puberty? That's the thing that's really going to determine it more than an age cutoff. So, you know, if you've got a small 12-year-old and you're thinking, yeah, I can cric this kid, think again, because it may not go as well as you want. The ET tube size, I'm not going to even talk about the equation. I put it there just so that if you decide you want to do math or you want to know it for a test question, that's fine. But really, the biggest thing I can say on your ET tube size, your drug dosing, your boluses, your eye gel size, your depth of tube insertion. Consult your PEDS cards. Do not rely on trying to do math on an equation that you're not very good at remembering when you have a sick kid in front of you. So early on, I would get a length-based tape out, measure the kid, and use the PEDS cards, because I think that will save you a lot of potential for mistakes, take a lot of weight off of your head, and allow you to think about the case that's in front of you rather than you sit there doing math or finding a calculator or trying to have to deal after the fact with the fact that maybe if you hadn't given 10 times too little epi, that this kid would have made it or not. Because usually when we see an error with kid math, the error is usually off by a factor of 10 or so. So I think that relying on something else to take that work, if I could tell you I've got a device that's going to make this much easier for you and is going to take your work away from you, you're going to love that. Well, it's there, and it's the PEDS cards, and use them. iGel, King LT, those are available in sizes that are very small. I forgot to mention earlier, but Joe and I have been talking about getting the EMTs trained up for iGel administration. That's something that I think both of us are very interested in doing. Wes Pierce did that, and it took the entire month of June to make it happen, but I'm pretty happy with the program. And so Wes Pierce now has 100% EMT certification for iGel administration. And so far, I don't think we've had someone throw one in the field yet, because we're just finishing up our paperwork that needs to be submitted, meaning that the stuff to the state so they can sign off on it, and the paperwork that we're going to be having each one of them fill out just kind of in the early period, just kind of to keep an eye on how it goes. Needle crikes. So you're going to be using a 14 to 18 gauge needle. Your goal is to go through the cricoid membrane. You're going to be using there's a couple ways to do it. And whether you're either going to be using a 3 cc syringe and a 7.5 ET tube connector, that's what I have shown here, or whether you're going to be using a 3.0 ET tube connector and connected straight to the angiocath, or whether you're going to be putting a lure lock in the middle there. That's all up to style. But I think there's a lot of ways to do it, but it's something that I would have it established in advance rather than after the fact. Just because trying to assemble a hobby kit and remember sizes in the middle of this is a bad thing. For me, and when I say for me, I have not done a needle cricothyrotomy on a kid, so I'm going to lead with that, right? It's not something I've done. I'm not someone that would consider myself an expert in the procedure. I've done similar things to adults. I used to use a kit that was similar to this for adult crikes, but I've gone to the other method with the blade and the bougie because I think it's more simple. Anyway, though, for the needle crike, I do like to have some saline in the syringe. That way I can be sure that once I'm in there, that I'm actually getting air bubbles back and I'm not just getting some sort of, I don't know, I just like to have that visual reminder that I'm in the right place. Yeah. So again, I've already hit this, so I'm not going to hit it again. But really, when you start looking at literature, there's really no study that tells you this. It's all based on size of the kid. But really, that 10 to 12 is the most common used, and you'll see some people throw out 8 for the open crike. Circulation. So the blood pressure drops are really late finding in kids. So they really can compensate well. The minimal SBP, the calculation's up there, but is also on the PEDS card. So I encourage you to use the PEDS cards, as I said earlier. But the signs of shock are going to be increased heart rate, increased respiratory rate. They're going to get mottled. They're going to start getting cool. They're going to get altered. And then their cap refill is a reliable finding in kids unless the environment is cold. If they're cold, then the cap refill is not as reliable as we'd like it to be. So per ATLS, we can bolus 20 cc's and we can repeat it. There is some tolerance of permissive hypotension. So if you're at near that minimal SBP and they're compensating well, you probably can get away with watching them, but I think that you're going to want to be ready to bolus early. And then I think that once the whole blood program exists, if you've bolused a kid twice and you're concerned about significant bleeding, then really you should be moving to blood rather than more IV fluids. Think about an IO very early in kids. You know, that's both for medical and for trauma kids if they're sick, because a clamped down kid is not the person you're going to be wanting to look for an IV. So think about your IO early. There's always that question of when can we use the humeral head, and I knew that was going to come up, so I asked Lila that very question yesterday, and she said she's never placed an humeral IO in a kid. And I said, well, what if it's an 18-year-old? She's like, well, that's probably okay. And I said, well, where would you be okay with it? And she said, if it's a kid who's gone through puberty, then you can presume that they now have an ossified humeral head and it's safe to use. But her go-to sites are going to be the proximal and distal tib, as well as the distal femur, prior to going to that humeral head in most kids. So that's the answer from the pediatrician. So when you look at what affects perfusion, and this applies to adults, so blood pressure is based on your systemic vascular resistance and your cardiac output. Kids are really good at clamping down, and that's why when they get cold or they get sick, they get all mottled and their hands turn blue. Cardiac output, they can affect mainly through their heart rate. Because they can get their heart rate up to 180, 190, sometimes 200 if they're really sick. But their stroke volume, they can't affect as much. The things that affect stroke volume are the preload, right? So that's what's returning to the heart. That's their volume status. That's the blood. So by giving them boluses, giving them blood, we can fix that preload issue. The afterload is based on the systemic vascular resistance, and we don't have a whole lot of control over that. Kids do not have, when you think about the heart of a small kid, granted, if you're talking about a 17-year-old athlete, yeah, they're going to be able to affect their contractility. If you're talking about a 2-year-old, and if you look at anatomy of a 2-year-old heart, they've got this thin-walled, very low musculature of their heart, and they do not have the ability to increase their contractility. They really can't increase that stroke volume. So if you think about Lance Armstrong and his heart rate of 20 beats per minute, that's all stroke volume and not much rate. Kids are the complete opposite, right? They're a 2-stroke engine. They can increase the speed of their heart rate. They cannot increase the contractility much. Now that gets better as they get older. And once you're above 8, you're kind of thinking that these kids are more like small adults than they are like the little kids. But just remember that kids are pretty limited in how they can compensate. And in the same way, they're going to be limited in how they're going to tell you. So the tachycardic mottled kid is a sick kid. And the issue with that is that they can increase their systemic vascular resistance to a point, and they can't clamp down anymore. They can increase their cardiac output by getting their heart rate to go faster, but once they're tacking out as fast as they can't compensate anymore. So once they start to drop from compensated shock to decompensated shock, it's a cliff, and they go off of it, and then suddenly they go from sick and then to decompensation to hypotensive, hypoperfused, hypothermic, and that triangle we talked about earlier kicks in, and then they die. Like that. Yeah, right in the cornhole. But he was fine. I don't really know. I have no idea. Actually, it's a really meta slide because it's a guy filming a guy filming a guy. That's like is there also another guy filming the guy filming the guy filming the guy filming the guy? I don't know. But it was extremely meta to me. But he cleared it. He can at least say that I cleared it. Yeah. So head injuries are a huge cause of death in kids, right? Why is that? So the picture down at the bottom, you can see, that's not a picture of Joe with no clothes on the far left. That's actually it's not a picture of a giant baby either. So it's just kind of the scale of when you look at that size of the head versus the size of the body, right? So you look at the kids, their head size is enormous compared to the rest of their body, and as they become adults, their head doesn't really grow that much. Their body just sort of fills in. So kids are lawn darts, and so probably most of you've never even seen lawn darts. I owned a set when I was little. And our fun game was we'd actually throw them up in the air and then run around to see if they hit any of us. We actually did that. And amazingly, we all survived except for Jimmy. No, it was just kind of the idiot. And this is probably the reason that boys die of stupid stuff, because we do stupid things. Anyway, though, so kids are lawn darts, right? They go head first. They fall out the window. They lead with their head. They're in a car and they're not restrained and they're not in the car seat and they're not belted. They lead with their head and they go out the window. They, get hit by a car and fly off of a bicycle. Again, they lead with their head. So really, you need to be thinking about head injuries in kids. Falls are more common than anything else, but falls, MVAs, motor pedestrian, bicycle accidents, and then assaults. 90% of these are considered minor injuries. Now that's a tough thing to really say and back up, but it's, a lot of times it's just stuff that you wouldn't think is a big deal. And really the smaller the kid is, the bigger the deal the minor accident is. 4 to 6% of kids with a normal exam have an intracranial bleed. And again, this is something that, for your 18-year-old, well, almost 18-year-old, you're probably going to have a pretty reliable physical exam and you're going to know if this kid's fine or not. However, for a kid that's 2 months old or 3 months old or 6 months old, your exam is garbage. Not because of you, but it's because you're examining a potato that poops, pees, and cries. And really, there's not much you can figure out, right? Because you're sort of like, well, is he crying because he's really sick and he's got a head bleed? Or is he crying because he's pissed that I'm poking him and it's nap time and he's hungry? There's no way to know. So the thing I would caution you is that the younger the kid, the more worried I would be, and the more likely I would be to transfer the kid or to transport the kid and not blow off anything, because these are the kids that are going to bite you in the butt, both medically and from a trauma standpoint, because you have to recognize going into it that your exam and your history is limited. The other thing that goes into small kids is that the potential for abuse is also there. And I'll talk a little bit more about non-accidental trauma, but when you've got a kid who can't give you a history, an adult who is unwilling to give you an honest history, that's a recipe for disaster. So you have a kid that can't tell you that they were shaken or beat or thrown down the stairs or whatever, and an adult who is lying to you, then you just don't know, right? And so I think that for younger kids, I just have a threshold to do more. And if I were in the field, that would mean that I would be extra cautious, and the smaller the kid, the more likely I would be to transport that kid. So differences between adults and kids. So there's some protective features. The smaller kids, until their sutures close and their fontanelles close, they have some ability to expand their brain volume. So the fontanelles can allow for a little bit of plasticity and things to allow for expansion of pressure. The sutures, when they're open, meaning that if you get increased intracranial pressure, your skull will separate and your head will get bigger to allow for that increased pressure. Now, as the sutures fuse, as the fontanelles close, and that happens, between 6 months and a year, then that goes away. The skull's also somewhat plastic because it's more cartilaginous, and that can actually expand. But on the other side of that, the skull is a little softer and can transmit energy easily. The problems with head injuries is that, big head equals more torque. So for a kid that's in a front-facing car seat and a deceleration injury, that's a big head, it's an apple on a stick. So that's a lot of torque on the neck and more likely to have C-spine injuries. I said the soft cranium's less protective. And then also the brain has less myelin, meaning that you don't have that myelin that's providing some cushion in there, meaning that you now have areas of the brain that are more dense and less dense. And when you get a big deceleration injury, you get this shear, meaning that some parts move forward and decelerate faster than others. And as it sloshes around, you then get this axonal shear, which means that the neurons are being clipped off. And when that happens, that means there's significant brain injury as a result of that deceleration. Concerning features, so in kids that do have open fontanelles, you may feel that the fontanelle is bulging or full. You may see that the sutures are splitting open. They may have altered LOC. They can be irritable. Persistent emesis is a tough finding, right? Because some babies puke all the time, some don't. So persistent emesis. Setting sun sign is a sign of increased intracranial pressure. That's the picture down in the corner where the iris is sort of sitting at half mast there. And actually I've seen that one time in a real kid. That's when I was at St. Clair, saw a kid with a brain tumor who, when I did the exam, was doing that and while looking at me. So that's another thing you can look for. Looking for evidence of a skull fracture. So scalp hematomas are the most sensitive thing to help determine if there's an intracranial problem. In a kid that is, there are these sheets, that, these algorithms that go through like how big the hematoma is, where the hematoma is. If it's a frontal hematoma, it's not as big of a deal as a hematoma that's on the temporal regions or the parietal region. I think that, a frontal hematoma in an older kid that has normal mental status, I'm not that worried about. However, smaller kid, any sort of scalp hematoma makes me worried. Depressed LOC, seizures should make you worried. And, if they have an LOC, and when and I'll talk about the traumatic brain injury criteria, but, LOC greater than 5 minutes is worrisome. I think really presence or absence of LOC at any point is concerning for me, because I think if I'm waiting around 5 minutes to figure out how long it's going to last, I'm concerned. This is the PCARN rules. There's the under 2 and over 2. And I just put these up there because, one, I want you to know that kind of the factors that we care about in the ER. This is not something that, this is kind of a way to determine whether the kid needs imaging or not. But I think that it's also good to know that if you're calling Marybridge, these are the things they're going to care about, right? Because if you look over there at the bottom left corner where it says high risk, where there's 4%, 4.4% of clinically important traumatic brain injury, usually that means a bleed on the CT scan. If you're seeing that their GCS is down, they have a palpable skull fracture, or they have altered mental status, then that's worrisome and they need to get imaged. And their risk of having a bleed in under 2 years of age is 4%. You go to the middle and you look at the criteria there, right? So scalp hematoma, LOC greater than 5 seconds, not acting normally per their parent, severe mechanism, so that's a fall more than 3 feet, MVA with ejection, rollover fatality, bike pedestrian versus vehicle without a helmet, or struck by a high impact object. If those are present, then they advise, so that's an intermediate risk. That means that there's a 0.9% of some clinically important traumatic brain injury. So that means that they probably need to be observed. The people that don't meet any of those criteria, they're the ones that are fairly low risk. And you can see by that the risk of a problem is less than 0.02%. So based on that, if you're on the base station physician with Marybridge and you've got somebody who is reliable and they don't meet any of those criteria and you're finding yourself in that low risk area, would it be reasonable to ask about potentially having private auto transport down to Marybridge to get checked out? I think that would be a reasonable ask. Now, the other things to look at over there in the corner is that, again, if the kid's less than 3 months old, if the parent's scared, if there's anything else that's worsening during observation, right? Because this is all built on the fact that these kids are being observed. Now, could you say that, well, couldn't they just observe the kid at home? You could probably say that. However, if you're an hour out now and the kid's getting worse, you've now delayed things an hour. If that hour happens at a hospital and you're like, well, let's just scan them, that scan can happen immediately. If you're now an hour out and the kid's at home and you're saying, well, we're not going to scan them, or if you're an hour out and you're saying, yeah, we need to scan them, and they're at home, then you're starting the ball rolling from that whole thing. So I would say that for those ones on the right, they almost definitely are going to need to get transported and observed, and the ones down in the bottom probably would be okay for POV. Same thing here. I'm not going to go over the details of this because they're practically the same. This is called the PCARN rule. But again, the reason I think it's important to at least talk about it is these are the things that they're going to care about at the base station, because these are the things that they're going to be asking about and determining whether they need to do a CT scan. Boop. and that's a physics lesson. So classification of brain injury, and I put this up because this is like from the international, like this is the Trauma Society when they start defining classification of brain injury, right? So when you start thinking about a traumatic brain injury, it's mild if their LOC is less than 30 minutes, right? I mean, that's pretty amazing to me, right? Because if I'm thinking about somebody like, like they fall, they hit their head, they're unconscious, and I go off and make a cup of coffee and go use the bathroom and then come back, and they're still unconscious, and then they wake up at minute 28, and I'm like, oh, it's just a mild traumatic brain injury. But the thing about it is that this is a different criteria, right? So this is the true traumatic brain injury. So this is not just like a risk of brain injury, but this is the people that qualify for TBI. So they had LOC less than 30 minutes, they had a GCS of 13 to 15, and these are the criteria on the right is just they observe these, these are things that they're having to look at 24 hours out for some of these people. So for severe TBI, these are people that have a GCS of 8 and at LOC of greater than 24 hours. So you could pretty much say that, yeah, they're in a coma for at least a day, right? So moderate's somewhere in between there. So when you start looking at like the brain injury literature, it's a different thing, right? If you're thinking, like, oh, I had a mild head injury, this isn't where you are. This is the traumatic brain injury. But it just kind of paints a picture of where they sort of draw the lines. The first thing I want to lead off with, though, is that for mild TBI, that the push is to not injure mild TBI patients for pediatric patients, right? So you use validated scales like that PCARN rule we just went over. There's a couple other things. I like PCARN because it's pretty straightforward and simple and easy to find. But using evidence-based risk factors for prolonged recovery, and then really customize their return to activity. But the best thing on this for any of you that are parents that had a kid that had a concussion, especially if you had that happen about 3 or 4 years ago, where the rule at that time was you do not return back to activity until you are at your full baseline without any symptoms. They've now said, hey, you can't return to your sports until you're back to your full baseline. However, you're going back to school, you're studying, you're reading your books after 2 to 3 days of rest. And that's nice that they've come out and said that, because like I said, I've seen people in the ER that would bring their kid in and they're like on these concussion precautions, and they were on it for like a year and a half. And I had my cousin's kid had an injury, and she was like out of school for 14 months. And you're just sort of like, what's better? Like, is it better to have this kid completely non-participatory in anything for 14 months? Or is it just, look, this is the new normal. You're going back to school, and you just got to sort of start to roll with your concussive symptoms. But as I've said before, this is not my quote, but the injured brain cannot take a joke. And that's an important thing to remember, right? So when you have a head injured patient, we've got this patient who has had the initial insult. There's the thing that's happened that we cannot change, right? We can through prevention. However, once 911 is called, that kid's already fallen out a window, fallen off a motorbike without a helmet, been hit in the head with a baseball bat, whatever. That stuff has already happened. We cannot change that once we're called. However, our job is to look for the things that are going to make that worse. So we're avoiding hypoxia, hyper and hypoglycemia, hyper and hypotension, and really just being aggressive about treating those things and preventing them is where we're going to make a difference. There's a couple easy things we can do, and there's some harder things we can do, and then there's some stuff that has to happen that we can't do. But the target map, you want to try and have that at greater than 75% of the adjusted normal, right? So look at your PEDS cards and use the map and from your monitor and use that to figure out, do you need to treat them for hypotension? So first of all, we need to aggressively manage hypoxia and hypotension. And that's all about preventing secondary injury. Elevating the head of bed to 30 degrees is important because that's going to help with vascular drainage. And then you're going to really, these are all the simple things right here, right? And then you're going to avoid anything that's going to restrict vascular drainage from the head. So if you put a C-collar on, you want to make it fit, but you don't want to put it on so snug that it's going to restrict any vascular drainage. you're going to avoid securing the ET tube around the neck. And if you have to secure something around the neck, you don't want to do it, so it's going to restrict any sort of flow. And then we're going to be looking for increasing signs of impending herniation, right? And we know what these are: the blown pupil, the widening pulse pressure. That's the difficult one to figure out, but widening pulse pressure with hypertension and either bradycardia or tachycardia, the Cheyne-Stokes breathing, new development of hemiparesis, and then if they start doing either decorticate or decerebrate posturing. These are hard findings for ICP, which means that we need to be more aggressive, and I'll talk a little bit more about that. So the Monroe-Kelly doctrine, which sounds like some sort of treaty in which we acquired Alaska, but it's not. But if you look at what that is, it's really just thinking that the skull is a fixed space, and in a fixed space, there's only room for so much stuff, right? There's room for the brain, there's room for arterial blood. In normal situation, on the left side, there's room for CSF and for venous blood. Now, as the intracranial pressure starts to increase, right, you have a mass in there, you have edema, you have blood or hemorrhage, you start to compensate, right? And what can you compensate with? First, there's going to be decreased CSF, decreased venous blood in there as that gets pushed out. However, you're trying to maintain that arterial blood because that's your perfusing pressure, and you're trying to maintain that brain, right? Because if the brain is getting squished down, it's going to look for a way out, and that's usually going to be the foramen magnum, and that means that this person's going to start herniating. So on the far right, as that amount of edema and that mass starts to get larger in size, then there's no more CSF or venous blood that you can get out of there. So then you start to get this compromise of the arterial blood flow, and the brain starts to get pushed out of the skull, and they start to herniate, right? So that's pretty much the simple fact behind what is happening when a patient's herniating. So what can we do? So first of all, our goal is to preserve cerebral blood flow, right? The cerebral blood flow is the MAP, so the mean arterial pressure. If your monitor doesn't read it, you can calculate it. That's the systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. That's the calculation for MAP. But the MAP minus the intracranial pressure, which we can't calculate, is what is telling you the cerebral blood flow. So first thing you can do is if you have a kid that you think has a pretty significant increasing intracranial pressure, then they need to rapidly go to a place that is capable of pediatric neurosurgery as fast as possible, right? Because there's some stuff that we can do in the field and in the ER to try and fix that pressure a little bit. But really, if there's an expanding hematoma in there, really the only thing that's going to fix it is a neurosurgeon getting in, putting in a bolt, draining it, and if that's not working, then they're going to need to remove a part of the skull and allow that brain to expand so that the pressure is is no longer an issue, right? However, while we're on scene, while we're transporting the patient, we need to avoid hypoxia, right? So if we need to take that airway because of they're unresponsive and their tongue is obstructing the airway and causing them to be hypoxic, or if there's a lot of secretions in the airway, we need to fix that. We need to avoid hypercapnia, meaning that we should be following an end-tidal CO2 on these patients and not letting them get hypercapnic, because that is going to cause arterial dilation and increase their intracranial pressure. And we also need to avoid hypotension, because that means if their MAP is dropping and their intracranial pressure is steady, then we're getting decreased perfusion of the brain. And then also we need to be aggressive about treating seizures. We're not going to pre-treat seizures, right? We're not going to just give benzodiazepines because we think that they had a significant head injury and they might seize. However, once they start to seize, we're going to be aggressive about it. In the ER, we do pre-treat seizures, but we use things like Keppra and Dilantin that are seizure medications to prevent it, rather than just pre-treating with benzos. The problem with just treating with benzos in a patient that's awake is then you may be feeding into the hypercapnia and hypoxia. Now, of course, if you've got your patient that you've already taken their airway and you've intubated them and they're paralyzed and you want to give them sedation, I think benzos are a great choice in these cases, because benzos are going to be somewhat preventative in treating those seizures. What do we do next, right? What about meds? What about lidocaine? I think if you decide you want to pre-treat with lidocaine because you're worried about increased intracranial pressure and you hit with lidocaine before you administer your paralytics, I think that's reasonable, right? What about sucks? Sucks is right out, right? Really, because if you're thinking increased intracranial pressure and you're pulling out the sucks, then you really are going to have to explain yourself later and say, well, I gave a depolarizing paralytic and maybe transiently increase the intracranial pressure. If you're thinking to yourself, well, sucks, I like sucks because if I don't get that airway, they're only going to be paralyzed for 8 minutes. I would say that if you're pulling out the paralytic in a head-injured patient and you can't get that airway, you're probably still going to want to have them intubated in 8 to 10 minutes when that suck starts to wear off. So I think that argument's a little difficult to hold in here. Ketamine. Initial literature had said ketamine was no good if we were worried about increased intracranial pressure. However, recent literature says that, yeah, ketamine actually does cause an increase in the intracranial pressure, but rather than causing an increased intracranial pressure just for the hell of it, it's actually increasing the MAP, which means you're increasing the arterial blood flow, right? So ketamine causes increased arterial blood flow, so you're actually getting a better cerebral perfusion pressure with ketamine than you would be with Versed or etomidate or other things that you may be thinking that you're going to pull out instead of those agents. So I very much like ketamine in this because the side effect helps you. If they come to the ER, we're going to pull out things like mannitol or hypertonic saline. Airlift Northwest carries hypertonic saline, so if you do end up using Airlift Northwest, a couple advantages of calling Airlift, right? Because if you're always thinking, well, what are they going to do for me? 1, they've got packed red blood cells. 2, they've got hypertonic saline. 3, they have a helicopter. 3 things I wish I had. More the helicopter than the other 2. But so just remember that they do have some additional stuff. And then what about hyperventilation, right? What about hyperventilation? So this is the most important slide that I'm putting up here, right? So if there's one slide that you're going to pay attention to and read and not look at any, it would probably, one, I'd be the guy that cornholes himself, jump in the pond. The next one would be this one. So this is probably the second most important slide. But really, so when you think about hyperventilation, it does lower intracranial pressure. But how does it do it? It does it by decreasing the amount of circulating CO2, right? So it causes hypocapnia. What does that cause? That causes vascular constriction, right? So that decreases the amount of blood flow, arterial blood flow going to the brain, right? So that means 2 things. 1, you're preserving the intracranial pressure by sacrificing cerebral blood flow. That's a horrible thing, right? You're really robbing Peter to pay Paul at this point, right? You're trying to prevent someone from herniating by decreasing the amount of perfusion to their brain. So when you start thinking about that, so if you cause profound hypocapnia, that's going to cause ischemia. So there's 2 lessons from that, right? 1 is that if you do intubate this patient, you want to pay attention to that CO2. And if you've got someone who's traumatically brain injured and you're not seeing signs of impending herniation, you want to have a normal end tidal CO2 on that patient, meaning that you want to keep that end tidal between 35 and 45, probably 35 to 40 would be the safe range in a head injured patient that you're intubated, because if you're overventilating them and causing hypocapnia, then you're causing ischemia to the brain. So that's the first lesson that you can take from this. The second lesson is that if you are, and this is something that I was trained to do, Joe was probably trained to do this, that if you were suspicious that they may have increased intracranial pressure, then you would do prophylactic hyperventilation, right? I would say that if you do not have signs of impending herniation, and we talked about what those are, that non-purposeful, non-targeted prophylactic hyperventilation is unsafe. And I would wager to say that as a result of non-purposeful, non-targeted prophylactic hyperventilation, that I have probably caused injury to patients because I did not know any better in the past. So I'm telling you this because that, 1, this is your chance probably to make the biggest difference in a head injured patient. If you are seeing signs of impending herniation, then yeah, moderate hyperventilation can be performed, but again, you need to have an end tidal CO2, and I would put my target at 32 to 35. If you're shooting for lower than that, if you're shooting for less than 30, if you're shooting for 28, there are studies that have shown that you are directly impacting patient mortality. So if you're hyperventilating people down below 30 or 28, you are putting bodies in boxes. So that would be my soapbox about this. And again, if you're going to remember one thing from what I say today, this would probably be it. So we've talked about this already, that head injuries can bleed a lot, and a small scalp lac can cause a lot of bleeding. There's actually a lady, this is kind of just an aside, there's a lady I had last year or 2 years ago, came from the fair. She was getting off the Dipsy Doodle or something, and then lost her footing when she went to step from one unstable platform to another one. Feet went out from under her, landed on her head, and had this laceration on her head. And she comes to the ER, pressure dressing's on, we pull it off, a pretty quick transport. And I look, and I'm like trying to figure out where, but there's this big mass of clot and hair. And the tech that was working on her was pretty new. And I said, look, I'm going to need to get this bleeding to stop, but I need you to clear this hair out of the way, because right now I can't see anything. So I need you to start irrigating this. And when you get it cleared, give me a shout. So, I'm kind of going about business, and about 30 minutes go by, and I don't get a phone call from the tech saying, hey, we're ready to take a look. And, so I'm like, this is odd. And so I go back to the room, and I'm walking up, and the curtain's closed. And, she's been put in the room the normal way with her head towards the wall. And as I walk up and look at the curtain, I see this puddle of blood that is all the way to the curtain at the door. And so I open up the curtain, and there's a 4x8 puddle of blood on the floor. And I was like, what the hell? And he's like, well, I couldn't get it exposed enough, so I didn't want to bug you. I'm like, no, when there's blood pooling on the floor, that's a get me moment. But anyway, this lady actually got admitted because she bled out of her head enough that she had this big scalp lac. And actually, when we got it exposed, this thing was like a horseshoe, and it was probably about 6 inches this way, curved down 4 inches, and then curved back another 8. So she had this big old flap that was just bleeding. And I actually talked to the medics, because it's not like, hey, you screwed up, but it was like, man, that was a hell of a scalp lac. And they're like, yeah, it was weird because we would put pressure here, and then it would start bleeding over there. So I'd put pressure there, and then it would start bleeding down there, and I couldn't see it because there was so much blood, so I just pressure dressed all of it. And I was like, yeah, you pretty much, and so it was just, but the lesson for there is that scalps bleed a lot in adults. And if you take someone that's got significantly less blood volume and you get a significant amount of bleeding, they can bleed a lot. So C-spine injuries in kids, they're not common in kids, but when they do happen, they have a very high mortality. You can see there's a bimodal age distribution. They're usually associated with a head injury. They are usually from falls, MVAs, and sports, quite often trampolines, diving injuries. And you can see they're common in younger kids. And there's a couple reasons for that. One is in the little kids, those are the ones that fall out the windows and land on their heads, but also they're the kids that have the bigger head to body ratio. So when you have a decelerating injury in a kid in a front-facing car seat, then the neck is the fulcrum, and usually at about C3 or so, you have 2/3 of these injuries that happen above C2 or 3, or 2/3 of the injuries happen above C3, so they're high C-spine injuries, and those don't tend to do very well. Once the kids hit 11 or so, that's when you end up having more diving injuries. That's when kids are getting on snowboards, kids' friends are driving, and that's where your next risk of having C-spine injuries occur. So it's bimodal, and again, something to look for. The other thing to note is that we've talked about that fulcrum at C2, C3. We also, we've talked about cartilaginous bones, but kids have bigger head, more cartilaginous bones, laxer ligaments, so they're more likely to have an injury without a fracture. What's that mean, right? So that means if they're in the ER and they don't have symptoms, they may get some imaging, right? Usually we may start with an X-ray, may get a CT scan, or we may not do imaging, right? However, part of that is that they can have soft tissue injury of the spine, not so much the ligaments, but you're having spinal cord injury. So skiwara, spinal cord injury without radiologic abnormality. So that means that you don't have a fracture, but you have some sort of spinal cord injury. And usually that's thought to be more of edema from injury than from a flexion injury. And the thing about that is that it can be transient, meaning that it can happen initially and it can resolve, or it can happen up to 4 days after that initial injury. So this means that and they do show up on an MRI, but for a kid without symptoms, they're not going to be getting an MRI. So the thing to note is you may get called on a kid who is a few days after their injury and is having either paresthesias or trouble walking or some kind of motor problem. And that could be from the car accident that happened several days ago, even though this kid was seen, cleared, and told they were normal in the emergency department and had imaging done. So what I'm telling you is that, if you see someone that has some sort of abnormality, even if it doesn't make sense, there can be something wrong. So take those seriously. Other concerning injuries, if you're looking at a penetrating injury to the neck, these pictures are of the platysma. So those are your shaving muscles. This guy probably below is shaving while pooping, maybe. I'm not really sure because that's why I only included the top part of the picture. I don't know. It's weird that he's a naked pooper. That's very, very weird. But anyway, so for neck injuries, if you see that the platysma has been violated, you should be worried. Things that also should be worried, if you've got voice changes, brisk bleeding, expanding hematoma, if you're seeing sub-Q air, bubbles out of the wound, those are all your worrisome findings of neck injuries. Really, I would just say if there's a hole in the neck, you should be worried. Because when you think about the neck, there's a guy named Billy Mallon. He works down in LA. I think he ended up going to somewhere in New York. He's a big emergency medicine guy. He's a guru, and he's well known for being foul-mouthed. But his saying is that pound for pound, there's not a lot of unimportant shit in the neck. And that's absolutely true. So if you're worried about neck injury, if you've got any evidence of penetration to the neck, rather than hem and haw about it, get them checked out. Because really, neck injuries are, there's a reason they use guillotines to kill people, right? Because it cuts someone's head off at the neck, right? It works. So just remember that everything in the neck is important. So chest trauma, second leading cause of pediatric death. It's the compliant chest wall I already discussed. The pulmonary contusions are common. Kids aren't as likely as adults to get aortic injuries, but they can happen. You can also get myocardial contusions. So for the kid that gets slugged in the chest with a significant amount of force, a myocardial contusions can present with EKG abnormalities, or you can have a kid that they've got some sort of shock to the heart, and because of the injury, isn't that a Bon Jovi song? Yeah, I know it. I'm not breaking into it. But anyway, so they have some sort of insult to the heart, and then they'll have decreased perfusion, right? And that can be from direct trauma to the heart, not necessarily penetrating trauma. And then remember, pneumothoraces can happen to kids. So chest trauma is more likely to cause hypoxia due to that lack of pulmonary reserve that we talked about. Abdominal trauma, that's number 3. But if you start looking at the causes of occult fatal injury, that's it, right? So for the kid that's not in the that's in a seatbelt that shouldn't be, the seatbelt doesn't fit right? Seatbelts are made for adults, so if you put a kid in there, they're going to have internal injury. They can have blunt trauma from MVAs, from bikes, sports, assaults, and just think about what's in there, right? So you've got this kid with a smaller rib volume, less protective ribs. The ribs aren't covering the liver. There's part of the liver poking down. The spleen is poking down on the side. So if they get trauma to the abdomen, they can get direct injury to those things. If you think about where seatbelt would sit on a kid, that's going to be a little too high. If you think about where bicycle handles hit a kid, that's going to be right over that belly button whenever they have a deceleration wreck, and that can cause a nice either injury to the duodenum that goes right under the belly button, injury to the pancreas, which is under the belly button, or the spleen or the liver. So that all is possibly going to happen. Again, they've got larger solid organs for their body size. They're more anterior, more vascular, and they don't have this amazing six-pack abs that I have to protect them. They also have a more compact torso. They have an elastic rib cage. The kidneys are more mobile, so that can cause some vascular shear. So that really has a potential for more internal injury, more to the solid organs. So the spleen, the liver, kidneys, pancreas, and intestines are the things that are going to get hurt in that order. There's a small possibility that they can have bladder injury, but that's not as common. Non-accidental trauma, so we're wrapping up on this. I did talk about this a little bit before, but 1 to 1.5% of all kids are abused each year. They're more likely to be abused by caregivers who are young, poor, and of minority status. However, that doesn't mean those are the only people that do it, right? So it still can be old, rich, non-minority people that could be doing this, right? So I would say that you should all go into almost every situation that if something doesn't pass the sniff test, you should be worried about it. The younger the kid is, the more likely they are to die from abuse. After skin lesions, meaning pinches, suspicious bruises, and burns, fractures are the second most common presentation. So bones that fracture under tension with torsion, meaning that you shouldn't be seeing spiral fractures of a femur in a kid who's not walking. Now, there are fractures that can occur in ambulatory kids and kids that are riding bikes, being hit by cars. They can get fractures, but really be suspicious in especially the kids that can't walk that are presenting with injuries that don't make sense. So non-accidental trauma, 32% of the time it's misdiagnosed before it's caught. 60% of the time people have prior history, and 22% of the time there's CPS already involved. So part of the importance in making a call to CPS, it's not only expressing your concerns, but also it's informational in the sense that you make that call because you're a little bit concerned and you find out that 3 other people have also been concerned in the past. Well, that's entirely different, and now that's suddenly you're identifying a kid that probably needs to be put into a safer environment. And I think that's what I got. You can see that's actually me in the porch with my 6-pack abs, actually. But I was fine. I just rebuilt that thing the same way I did the first time. So I don't know if we've got any questions, anything. Nothing. Not one single question. Okay. We're going to take a quick break, and then we're going to go over some cases. Are we going to leave the stream running during our quick break? All right, so we're going to go over some cases. I don't know if there's been any questions come up during the break, so if you do have any, yeah, please put them in the chat box. But let's go over some cases. This one is a 3-year-old stepped on a ball, led him to fall backwards, strike the back of his head on the concrete ground. Family denies LOC, but subsequently became very lethargic. Denies medications or medical history. It's found in the care of engine 113, skin's pink, warm, and dry. GCS initially presents as 116, but patient would squeeze his eyelids tightly when trying to assess pupils. Would also open eyes slightly when not being assessed. Blood pressure is 100 by palp. Respiratory rate 24, regular. Heart rate 98. DEXI was 101. Difficult to assess CMS due to patient not moving his extremities. So it paints a picture of a kid that's, I don't know, to me, sounds like they're painting a picture of a kid that's kind of playing possum. I think those are good ways to sort of suggest what you're thinking without saying kid seems like they might be faking. Anyway, so he's called AL, ultra-level conscious secondary to fall. They transported him to Marybridge. They did do a DEXI. So during transport, patient had minimal response, including not moving during DEXI stick, which, you know, for a 3-year-old, that's a lot, right? You're going to poke the kid in the finger, and they don't do much, right? So I think that is a little bit concerning. I think it's right that they transported him. But then several minutes later, patient opened his eyes and then started interacting with dad. So was there some sort of alteration there or not? I don't know. He remained awake for the remainder of transport, but does appear somewhat lethargic. So he went to Marybridge. He did get imaging of his head, which was normal. He was observed in the ER for a little while, and then returned to baseline mental status, appeared well, and then was discharged home. But I think the notes on this are good. They got vitals. They got a complete set of vitals. They even measured an end tidal on him. They checked a SAT on him, which remained normal, and then they checked a DEXI. And I think that really in kids, it is important to check DEXIs just because in younger kids, do they have some sort of undiagnosed metabolic issue? Maybe. Or, you know, and just remembering that kids don't have good glucose reserves, so they can get hypoglycemic easier than adults. Also, I mean, the fact that they've got a palpated blood pressure on a kid is good. And I would say that even though a lot of people have been in the habit of not getting blood pressures on kids, I think that really, that especially if you have a kid that you have any potential to be worried about, you need complete vitals, including a blood pressure. It's the standard of care. Even though it's a pain in the butt, it's something that, you know, it's hard to explain why you didn't do it if a kid is sick. Let's go down here. So this one is not my redacted one, is it? Oh, it is redacted. He just didn't redact it the way we normally do. So it's a redacted one, so I just want to make sure I wasn't giving out info. This is a 2-year-old. This is a recent case. And so you see a lot of stuff's happened. Just getting the story. So this is a report of a cardiac arrest in a 2-year-old. This is a 2-year-old that was found lying on the ground next to above ground pool, CPR in progress by a relative. Family states patient discovered floating in the water unattended. Possible downtime was about 10 minutes. On further history from Marybridge, they said that kid had been last seen 30 minutes prior. So, you know, 10 to 30 minutes, but we get the story we get. Patient was removed, 911 was called. They were given phone CPR instructions from dispatch. Patient was apneic when taken from the pool. Family states the patient has no medical history, does not take meds. Airways patent. Patient's apneic, no brachial or carotid pulses noted. Chest compressions were resumed. BVM, the number 2 eye gel was placed. O2 filter line placed and confirmed. IO was placed. Quick combo pads applied. PEA disorganized rhythm noted. CPR was continued. Patient measured with weight-based tape and then measured at 15 kilos. Epi was given with a flush. Rapid trauma assessment was done. The HENT was atraumatic to palpation. Thorax was stable. Abdomen soft, non-tender, no obvious trauma. Pelvis was stable. Extremities had slight pallor. History from family. Second epi was administered. Patient was placed on the cot and then transferred while maintaining CPR throughout. In Medic 61, the I-gel was reconfirmed en route, priority Marybridge with 3 additional firefighters. Approximately 13:35, movement noted during compressor change, carotid pulse noted. To protect airway, patient was given RSI meds. 4.5 ET tube was placed. Patient was ventilated but could not confirm correct placement. End tidal CO2 sat was declined. Tube was removed. NG tube was placed to deflate stomach, and the I-gel was replaced with improvement in numbers. Ketamine was administered. They were met at the Marybridge doors by staff. Care was transferred to Marybridge. I-gel was reconfirmed with transfer. So it was a respiratory arrest, PEA. ABC check, CPR, this is kind of the sum up. So I think that's all in the history. But you can see, and I think there were a lot of things that happened really well on this call. The fact that they kind of early on, started with the I-gel, right? So I think PEDS airways are pretty scary. I think I-gels are something that I think if you can put an I-gel in a lot faster, then you can start a line and drop your drug. So the I-gel went in early, and then quick IO administration rather than searching for a line in a shocky kid. I think that was smart. It looks like CPR was good. The epi was needed, but really, when you think about drowning calls, and you think about kids versus adults, right? Kids arrest because they get hypoxic, because they get airway issues, right? So you need to fix the problem that led to the arrest. So by putting in the I-gel, oxygenating the kid, you're addressing the physiology that led to the cardiac arrest. So if you're going into a kid cardiac arrest and you're thinking, that this was primary cardiac, it just doesn't happen in kids, right? Kids don't go, get ready for work and then have an MI and then have a ventricular tachyarrhythmia and then drop on the ground. That's not what kids do. Kids choke on toys, kids drown. So really, when you're thinking about how you're going to fix the problem, it's about oxygenation and fixing the airway. So that was done really fast. The IO was done really fast. So this kid went to Marybridge. I just want to see if there's any other interventions to make comments on. I think his report's really good. But kid went to Marybridge, was seen in the emergency department, did get a head CT just because the history was not, they just didn't trust the history, which, you can't really trust because you don't know if there was a diving injury, a fall, what happened. So they CT'd the kid's head, and CT head was normal. Kid was admitted to the ICU, spent yesterday in the ICU sedated, but was having some signs of some purposeful movements last night. And from what Brett said this morning, kid is extubated. I didn't see a doc's note in the computer this morning yet, but kid's extubated and doing surprisingly well. And I think that probably the things that really fed into that is, just to give credit to dispatch for starting telephone CPR early, I think that was huge. And then I think this crew did a really Herculean job at doing a really good job and probably really helped with the recovery of this kid. So, anything else? Joe, you want your microphone?
I would just like to add that that we had a meeting yesterday with Lila O'Mahony, also involved Captain Lickabaugh, Dr. Frederick, and myself. We talked about this call. The meeting was regarding how we're going to run pediatric out-of-hospital cardiac arrests in the county, and the standard that's going to be set, I-gel or supraglottic device versus intubation, IO versus IV, and everything that this crew did worked great. It's exactly how we want to see it. Additionally, what Martinson was telling me this morning, that the new PEDS cards made this code go way better, a lot less stress, run a lot more smoothly, which is exactly what we want to hear. Mostly, I just want to say congratulations to the crew for doing such a fantastic job on this call.
All right. I don't know if we've got any questions so far, but if you do, let me know. Let's see. I can't see that far away, but now I can't use my mouse from up close. So, all right. Yeah, let me pull up a couple more of these. Okay, next up. So this one is a 15-year-old that was 200-pound 15-year-old. And I think it is good to comment on pediatric weights, right? Because the weight of a 15-year-old is all over the place. You know, so a 200-pound 15-year-old versus a 85-pound 15-year-old, you know, they're different people, right? But anyway, so no past medical history. Crosswalk by a passenger vehicle traveling about 30 to 40 miles an hour on Pacific Avenue, striking the windshield and landing about 40 feet from where he was struck. States he remembers being hit in the chain of events afterward, complaining primarily of 10 out of 10 pain to his lower leg, 2 out of 10 pain to his chin. Has no other complaints at this time, specifically denying nausea, vomiting, headache, head, neck, back pain, or difficulty managing his secretions, right? And so the thing that's really notable is when you start looking at a 15-year-old, and if you compare this to, like, you have exact same case in a 1-year-old, right? Well, first of all, you know, the 1-year-old's a lot smaller, but the thing is that the 1-year-old's not going to localize the area of pain for you. The 1-year-old is not going to be able to deny or affirm whether they've got nausea, vomiting, headache, head, neck, back pain, difficulty. So it's a completely different patient when you deal with that, right? So the 15-year-old's pretty close to an adult. And that was part of the reason that the Adult Trauma Center is sort of moving forward to sort of pick up a lot of these injured patients. I don't think that's been completely affirmed in the protocol yet, but that's something that is moving down the road, right? So that for, you know, let's say this guy, you know, he does meet step 3 criteria. Looking to see what else. So yeah, he's going to meet step 3 criteria and end up at adult. But let's say this kid was just kind of an injured patient. In the future, and when the future will happen is I'm not sure, but we've submitted it to the state. But to get things more simple, we are going to have the adultish, so the 15 or greater year-old injured patients are going to start going to the adult system. And the reason for that was because it was blurred. There were a lot of lines that ended up getting blurred, right? You get the patient who maybe didn't quite meet EMS criteria, got to the hospital, they found something, and then they were transferring a 16-year-old from Marybridge to the adult center. And that was just a lot of confusion because then, you know, we're on the phone with a patient who's not been worked up, who we've done our examination on, and they're asking us questions like, you know, like we're going to know whether they're going to be benefit from being at the adult facility, even though they don't meet our step criteria. So that'll hopefully simplify things because, you know, the thing that brought that to a head is there was a 15-year-old that was at one of the Western State buildings who jumped off of a wall, right? And the wall was I think, you know, it was like 10 feet high. So by step criteria, didn't meet the criteria. But then there's the, you know, they're on the phone and they're dealing with adult trauma who's saying, well, he doesn't meet criteria. And then PEDS like, well, except that he fell from greater than height. And you know, and granted the wall was this high, but how high was his head? And did he jump up, you know, then come down? And it was like this thing that turned into this miserable, like, multi-phone call thing. So as a result of that, we're trying to simplify it. And, you know, so injured patients are at some point, and you'll get a notice whenever it goes through, but we've already changed this. It's just now that because of the COVID, we're sort of on a delay. So that should be happening at some point, and when it happens, we will notify you, but I'm hoping it makes your job easier rather than more complicated, because I feel that having to make a decision of, is he steppable or is he just really injured? And that's just something that's not reasonable to ask you guys to make those calls. Anyway, so this guy's 40 feet from the crosswalk. He's getting C-spine held. He is tachycardic. He has a really good exam, so he's got a lac on his chin. Otherwise, airway looks okay. Lungs are okay. Abdomen soft, non-tender. Pelvis was stable. He had abrasions to both arms and right legs, and then there was some question of whether he has an open left tib-fib fracture. He was called a step 3 trauma since he was an auto-ped. He got his report taken, was put in a collar, went priority to TG. He had the vacuum splint placed. He was given fentanyl without relief, and then he was given a little bit of ketamine to have relief. Was put on end-tidal. Vitals were monitored, and his condition improved with the interventions. He was taken by the trauma team. They repaired his chin. I'm gonna, let's see, close current tab, minimize that. Here's a picture of his leg. It hurt a lot. They repaired his chin, and they imaged his brain and his neck, as well as most of the rest of him, and found no other internal injuries, no brain injury, no C-spine injury. They made this a bit more straight, and then they ended up fixing it in the OR. They didn't call it open, and I think that so I don't know. I don't know where the wound was, but they didn't mention that it was an open fracture. But I think that if you are worried that a fracture is open, I would much rather you say, I'm worried this fracture might be open, and let the physician or orthopedist or whoever make the call on that. Because what I don't want to have happen is that we don't tell that, and then we have an open fracture that we've had in a vacuum splint or some sort of immobilization, and there's not an early identification of that. So I think if you're worried about it being open, say that, because that means that there is some onus on the ER to start antibiotics early, get the person to the OR for a good washout. But sometimes that doesn't happen if we don't know it's there, because what happens is they go to x-ray and they're splinted, and we don't get a good look at it because we don't make that time to do that right away if we're not thinking it's open. Yes?
Just a quick comment online. Had a similar situation last week.
Yep.
Mary Bridge is kind of in limbo on this decision also.
Yep.
Had an injured patient that met the hospital trauma criteria.
Yep. Yeah, and unfortunately what's going on is this is something that was okayed by trauma, something that was okayed by Mary Bridge. Everybody is okay with the decision, and the delay is happening on the bureaucratic level, and it's the state that we're waiting for to kind of give us the thumbs up. So I apologize for that delay. I don't have much control over it. How are we doing for times? We okay? I'll do a couple more. Let's see. So these ones here, this is a pretty unfortunate. You guys probably remember this case, because these were some kids that were all in the same car. And I think the thing that's amazing about this is that the number of people involved in this, and that how well and okay some people did and how not okay other people did. So this is a 15-year-old who was a restrained passenger in a vehicle, left the road, rolled several times. Patient was able to self-extricate prior to EMS arrival. Patient had a chief complaint of hip pain and clavicle abrasion from the seatbelt. Denies LOC, denies headache, denies abdominal pain, denies pertinent past medical history or meds, denies using alcohol or drugs. Patient was a passenger in a vehicle that had an ejection with a fatality. And I think it's important to put that in your report, and also to recognize it too, because there have been times whenever, because I think the fatality, what it does, it paints the picture of the amount of force that was then involved in the collision. So Patient presents stable, ambulatory at scene, talking with PD, GCS 456, skin is normal, head, eyes, everything looks normal, exams well documented, right? There's a seatbelt abrasion to the clavicle, chest looks good, lungs are equal, back unremarkables. They do a really thorough exam there, and I think that really in a trauma patient with this much potential for injury, you need to have a good exam. Vitals were done and look rock solid normal. So this was a step 3 because of death in the vehicle. They did contact Marybridge, who then gave the okay to transfer to Good Sam. Patient was examined, seen, and imaged at Good Sam. Imaging was all normal. Patient was discharged on same day of accident. So let's go to a different patient from same accident. So this patient was ALS, so I think this was a 17-year-old ejected from a vehicle. So a 17-year-old male ejected from small SUV or sedan that rolled multiple times. Patient is unconscious, and per engine 66 crew, patient initially had agonal respirations and a pulse. Vehicle had significant damage, unable to obtain further secondary to patient's critical condition. And I think that's a worthwhile statement to put in there, right? Because you start looking and you're sort of like, well, this is a pretty sparse history. Saying why it's a sparse history is great, because, I mean, you're not, are you going to stand around and ask questions, or are you going to do something? And that statement says we did stuff rather than ask a bunch more questions because the patient was in critical condition. So past medical history is unknown. 17-year-old male, about 300 pounds, found laying supine in the ditch 100 to 150 feet away from the vehicle. GCS was 3 agonal respirations with a pulse per engine 66 crew. Skin was pale, warm, and dry. HENT. Bruising was noted to the forehead. Pupils were fixed and dilated with no JVD. Trachea was midline. Chest back was atraumatic. You had clear breath sounds with eye gel placement and bag valve mask. EKG was initially PEA at 80. Abdomen was atraumatic. Pelvis was intact to palpation. Upper and lower extremities, there was abrasion to the inside of the left arm at the elbow. Other extremities were atraumatic. So this was a step 1 trauma, multi-system trauma, and then a cardiac arrest. So patient had ABCs, nasopharyngeal airway, BVM. Patient had backboard Ducat emetic unit. Eye gel was placed. End-tidal CO2 waveform and number reading was taken prior to St. Joe's. EKG was done. End-tidal readings measured at 11 and unable to palpate pulse. CPR was started. IV phone report to Joe's. Step 1 trauma activation. Epi had no change. Needle decompression was placed at the mid-clavicular left chest with no change. Epi, no change. Needle decompression, mid-axillary and the right chest, no change. Epi, no change. Arrive at St. Joe's. Patient care to trauma team. And this gentleman ended up expiring. And as you can tell, and really, when you start looking at the potential for survival in blunt trauma, if you lose your vitals outside the hospital, your chances of survival are practically, if not none. So really, this kid didn't have much of a chance once his vitals were lost. I think they gave him the best chance they could, and I think rapid transport probably was all they could do, but I think that they did the stuff that could be done, but I think this guy had pretty overwhelming injury. That's an unfortunate case. I think I have one more from that ride, from that car. Is it this guy? I believe there were 4 occupants in that vehicle. Yeah, this is the guy that was pronounced dead on scene. So I think there were 4 total. 1 went to Good Sam. I don't know what happened to the other one, and then 2, one that was dead at time during transport, and then this guy who was dead on scene. So this one is a 16-year-old male laying in the yard 50 feet from the vehicle with Puyallup police doing CPR. Patient was apneic and pulseless. Puyallup police on scene report that patient was ejected from the vehicle in a high-speed rollover and was impaled feet first in the yard. Police report that they had to pull him from the yard and start CPR. Patient was asystole in 3 lead EKG and not breathing. Quick physical exam revealed cervical spine was unstable and there were no signs of life. Phoned to Good Sam for signal 3, time of death. Time of death was at 3:50 by Barnhart. And I think that, really, this one, has no vitals prior to EMS arrival and is blunt trauma. And so clearly he's not going to survive this. So I think that getting the history that you need to get is kind of the minimal of what you need to do. But this is pretty unfortunate. I'm going to do one more case, and then we'll wrap up. Let's see. This one is more just your reminder that it's kids fall out the window season, unfortunately. There's that big thing that, and I've said before that this thing, if you've done this whole exam, this is fine. And it actually looks like he did some edits in there, so he may have done the whole exam. But I think that just be careful that if you put this in your chart and it disagrees with your chart anywhere else, or you don't go through, like you see, like, because in the past we've seen like general exam, was normal, and so realistically, if it's not part of your exam, don't leave this in. If you use this and you actually go through and pay attention to it and edit it, yeah, by all means, use it. But I think that just, it's sort of one of those things that buyer beware, just in the same way that when I use dot phrases that talk about my patient exam, it's on me to go back in and correct stuff. Like if I say someone had normal extremity exam, but they had an amputation of both legs 20 years ago, that doesn't look good in my chart. So in the same way, just remember that. But I think that if you do that and use it, by all means use it. And it looks like he used it correctly by going back and editing it and making sure it did not, disagree with it. So anyway, so this is a 4-year-old walk-in at station 60. Chief complaint of a second-story fall from a window. Patient's family drove her to station 60 via POV. Patient's father states he found patient lying next to the trampoline, conscious and crying. Patient's parents both confirm fall was unwitnessed. Patient's mother states that patient was awake and crying for post-fall and never lost consciousness post-fall. Patient's mother states that she was watching fireworks from a second-story window. Patient mother denies patient having med history or allergies. So 4-year-old carried by mother on Dometic 60 gurney. GCS was 15. Skin color was appropriate, warm and dry. HNT showed a 1-inch laceration above the left eyebrow with controlled bleeding. Eyes were pearl at 3 millimeters. Ears negative for CSF. Airway was patent. Patient was crying and speaking full sentences. Neck was negative for JVD. Had good extension, flexion, and rotation. Negative for pain on palpation, negative for any deformity. Chest had equal rise and fall. Lung sounds were clear. SAT was good. Abdomen was soft and non-tender. Extremities were moving times 4. EKG showed sinus tach. Blood glucose was checked and normal. Had an IV placed. Patient was crying while mother was holding her. Mom was holding patient on her side. Mom state patient appeared normal for baseline at this time. GCS was 15. Patient consoled, able to answer questions, obeyed commands. Marybridge was contacted. Step 3 trauma was activated as it was a second-story fall. ALS transport to Marybridge ED. On gurney, mother holding patient en route to Marybridge ED. So Marybridge drop-off. Otherwise, so engine 60 accompanied for manpower without incident. So this kid did get imaged as well, and then observed at Marybridge. Imaging was okay. They repaired kid's head, imaged kid's head, and I believe neck also, both of which looked okay, and then kid ended up going home. But I think this is one of those things where I think last year, I can't remember how many window falls we had, but I think that as far as preventable injury, this is one of the ones we've been seeing significantly lately. Yeah, I don't know if we have any more questions. I don't know if you have any wrap-up or summary stuff, Joe, but I was going to wrap up unless you want more cases, but I think that's a pretty good number. All right, I'm going to let Joe talk a little bit.
Just two things real briefly. Just want to mention the EMS lieutenant test and the EMS captain test. Application period for those closes this Friday the 24th at noon. So if you're interested, make sure you get your application in. And lastly, I'd be curious to see what you guys think of EMS Connect so far. I know the classes are a little bit longer, but you're only doing 2 per quarter. And I feel like the value, the content is much better than what we had. Additionally, both ALS and BLS personnel are getting the same class. We see value in that as well. But send me the good and the bad, what you like about it, what you don't, so we can make decisions going forward. That's all I have.